Hi, everyone. So I'm going to talk about the nutrition management of ALS. And basically, as the dietitian in the ALS clinic, I work to identify and assess nutrition issues of the patients. I monitor the progression of symptoms because every patient who comes through the doors is going to have different nutrition symptoms as their disease progresses. And I develop a new nutrition care plan, and this plan is changing every time we see the patient. Like Dr. Tandon said, the patients, as they change, as their disease progresses, how they want to do things in terms of their nutrition is often changing as well. Basically, the nutrition management goals in a patient with ALS is to optimize oral intake to make sure they're getting as much nutrition in as possible, to make sure every calorie counts that is entering their body. We provide strategies to maintain body weight. We want to make sure that patients are able to achieve their current weight for as long as possible. I liaise with Anna, our speech language pathologist, who's going to be coming up and speaking to you right after me about swallowing management, because often with ALS and the bulbar functioning, swallowing changes occur with many of our patients. And I also am greatly involved with recommending nutrition alternatives such as feeding tubes in our ALS patients and monitoring their care as the disease progresses if they've chosen to have a feeding tube. Every person with ALS is different and requires different nutritional care. No two people are alike. And diet intervention, as I said, will change as the disease progresses. The biggest issues that we deal with ALS patients are dysphagia, which are swallowing issues, which Anna's going to talk about in a second. Weight loss, patients are often losing weight. I'll talk about that in a moment. Dehydration, which goes with the weight loss, the swallowing dysfunction, and the inability to eat as much, they're often becoming dehydrated. Saliva management, which we already discussed, which is occurring in many of our patients, and GI issues, which can be a multitude of different issues, such as constipation, reflux. The whole gamut of different GI issues are often occurring in our patients with them. So why are these things occurring? The bottom line is that they're having bulbar muscle weakness, which we talked about, that Dr. Eisenberg talked about, where their problems are happening in the upper motor system, leading to swallowing problems. They're having upper extremity weakness. So because their hands aren't working as well, they're not able to feed themselves and even to prepare food. The respiratory muscle weakness is occurring, so they're just exhausted. And often I have found that when a patient starts on BiPAP, their nutrition status often increases a little because they're not as tired, so they're able to eat better, so they work hand in hand. Because of GI issues, there's a loss or a poor appetite. They have this sense of fullness that's occurring. There's delayed gastric emptying. Often these patients are depressed because they have a disease. They don't want to eat anymore. That often occurs in the beginning of the disease. We often see this rapid weight loss that's occurring, and then some of them are able to eat a little better. And then constipation is a huge issue with our patients, just due to slower bowel function occurring, weakened muscles, and there's lots of GI issues occurring. So I'm constantly dealing with all of these issues and trying to come up with the best solutions to help all of them. The first word that someone comes into my office, they say to me, "So what diet am I supposed to be?" Ooh, something just went crash. I'm ignoring it, it's just the mouse. Everybody says to me, they sit down and they say, "Okay, Nicole, what is this diet I need to be following?" Unfortunately, I don't have a special diet for them to follow. They basically just need to be eating like all of us need to be eating. They need to be following Canada's Food Guide to Healthy Eating, just eating well, eating nutrient-rich diet, which will help slow down muscle atrophy, will strengthen immunity, and fight infection. But the other thing that's really important, and I always joke with them that I'm the only dietitian mostly in all of Sunnybrook, will tell them to eat whatever they want. If they want to have milkshakes every day, have milkshakes if they can swallow them. If they want to have French fries smothered in poutine, have it, because these cells need to be fed. They're hungry, and you need to feed them. And the ALS cells like to eat fat, so we want to feed them fat. So there needs to be an increase in overall calories, which with a focus on high-fat foods. This will provide more energy and help maintain the body's muscles. The other thing that's occurring is the fasciculations. And these fasciculations are like the muscles are working hard, and they're actually burning calories. So that's why there's this need to be having also more calories. So you want to just keep feeding the cells, and a person just needs to keep eating as much as they possibly can. Because my mouse fell, did the thing stop working? We'll just go like that. Nope. Nope. Okay, I can just talk without my slide. That's no problem.
Just mouse away from it.
Okay. So after they say, so Nicole, how many calories should I be eating? Because a lot of people are very concerned about calorie need. So we know that there is an increased need. Definitely there's a need for more calories for a person to be having. There's some research have developed a formula based on the Harris-Benedict equation, which is what dietitians use to determine how many calories a person needs. A very complex caloric amount that you need to have. But mostly for my patients, I use basically a 30 to 35 calories per kilogram of body weight, and then a bump in the protein of 1 to 1.5 grams per kilogram, because they need more calories. In terms of weight, most patients will lose weight prior to diagnosis. That's one of the things that just often occurs. And then we really try hard to try and maintain that current weight and prevent further weight loss. It's very hard for ALS patients to gain back the weight that they've already lost. So we're just trying to maintain the weight that they're at and do as much as we can to make sure they don't lose any ALS, more weight. Now, some patients, often you'll see that their weight starts to shift around, and many patients will develop what's known as an ALS belly, which they often just looks like they have a distended belly, it's just that the muscles, as there's just the weight shifts within their body. And we're just constantly monitoring weight and preventing unintended weight loss. Most of my patients say, I'm just exhausted from eating. So we're trying to get them to have as much food in to make them as less exhausted as possible. So we want to have small meals that are frequent. We often have to modify the textures, which I work with Anna to do. High calorie supplements, such as the products that are made by Abbott, 2-cal. I never just tell a person to have just basic Ensure or basic something. I'm always saying have the plus, have the double calorie, have as much calories in that one sip or bite as you possibly can. High calorie foods, eat the good high calorie foods and the bad stuff. So olive oil and avocados and nuts if they can swallow it, which are the good high calorie fatty foods, or even the bad ones like milkshakes and bacon and things with lots of meat, fat, and as much calories as you can possibly get. Often people are also struggling with food access issues, like being able to get to the grocery store, being able to prepare foods for themselves. So we deal with things like recommending Grocery Gateway, Meals on Wheels, friends making a meal train for them, or all kinds of things that we do to maximize oral intake. The role of supplements in ALS is every patient who comes to see me has Googled and found everything that they could ever possibly know. Everything has been studied, and more are going to be studied, and more things are going to come up. There's different protocols or different regimens that people are doing. They're getting stuff from the States. They're doing all kinds of things. The research will always continue in this area. Unfortunately, there's no concrete evidence that any of this works. However, if a patient feels that it's helping them, by no means, it's not, as long as it's not doing any harm, I never second guess it, unless they're really, the things that are the most biggest harms are their pocketbooks that could often be being depleted. But I work with them and just tell them, you can do this, but I can't promise you results, but they are all willing to try, and I work with them. And they often are teaching me things that I don't know about because they've been searching and searching, so I learn from them. So alternative feeding in ALS is a huge issue. Because of this swallowing issue and the exhaustion from eating, often people choose to have a feeding tube. It's a very big thing that we talk about often in early stages. We talk about it, and the conversation evolves as the disease progresses. The goal is to help maximize overall nutrition, maintain weight, conserve energy, and prevent dehydration, and to give medication via the feeding tube. And it's up to the patient. It's their decision to make if they want to have the feeding tube or not have the feeding tube. And it's a decision that's made by the patient with their family, and it's a decision that they come to make. And then once they've made that decision and they've been provided with the education, I provide them with the knowledge and help them get the feeding tube. And what most people aren't aware of, and they have to be told, is even if they have the feeding tube, they can still eat. I often say that the feeding tube is like an insurance policy. So you are getting the feeds to bump up your nutrition, but you can also eat for quality of life and to get that food enjoyment if you can. The evidence and the studies around feeding tubes is evolving, changing, but we know that suggests that the feeding tube will help stabilize body weight in most patients. Evidence suggests that a feeding tube will prolong survival in patients with ALS. There is no evidence, however, that supports there's an increase in quality of life. And the other thing is that everyone says to me, well, when should I have the feeding tube? There's no concrete evidence on when to place it, but we know that it's better to have it earlier as opposed to in a time of crisis. So if you are able to still eat, you're able to walk, you're not in any sort of immune issues, or your nutrition isn't as compromised, you're going through a medical procedure, it's better to have it earlier than when you're in that crisis mode and to have the procedure. We also know that there's the risks increase for PEG placement when FVC declines below 50%. So those are some of the things that we work with in terms of the feeding tube. The feeding tubes are placed by endoscopy by GI or radiology by interventional radiology. More of our patients are having it by interventional radiology because it's a quicker procedure and there's less issues in terms of their breathing functions. The patients are not given a full anesthetic. They're just given mild stuff because of their breathing. Most of our patients, which goes against the norm, we like to feed them by syringe, so it's just quicker and easier for them to have it done. If that doesn't work, we use a gravity feed or a pump, and education and liaison is done with me, with a CCIC dietitian, working with the patients with the disease and with their care. So basically, everyone should see a dietitian when they're going through the ALS, as they're an ALS patient. I see every patient in the clinic who has any nutritional issues. We look at changes in appetite, weight loss, swallowing issues, but my really goal is to maximize oral intake with the focus on high fat and high calorie foods for our patients and making sure they eat as well as possible. Like Karen, I'm not going to take any questions. Come find me because we're on a time crunch here, and so we can get through all the information. And now I believe Anna, our speech language pathologist, is going to come talk. So thank you very much.
So Anna Subramaniam is going to be speaking about swallowing, speech, and saliva. She's the speech language pathologist at the Assistive Technology Clinic and working in the ALS Neuromuscular Clinic. She's worked at ATC for 6 years and cared for a variety of patients with neurological disorders, including ALS, stroke, MS, and movement disorders. Please welcome her to the podium.
Hi, everyone. So today I'm going to give you a brief overview of what my role in the clinic is in terms of swallowing, saliva, and speech management. So forgive me if there are things that are left out. It's not an in-depth look at assessment and a really in-depth look at treatment because we're short on time. So in the clinic, my role is really to maximize functional communication and swallowing for our patients over the course of their disease. And so in doing that, I really look at these 3 S's. It helps guide my assessment and management. You'll see saliva on there. It's been discussed already, but it really does have an impact on both speech and swallowing. And so I'll explain that further. Swallowing. So you've heard a little bit about it, dysphagia management. So of course there's the assessment component, but what I really focus on is education, safe swallowing strategies, and food and liquid modifications as needed. I won't go into the feeding tube because Nicole's pretty much covered how we deal with it together and as a team. So with dysphagia, what you'll see in the primary bullets is some of the symptoms that patients will describe. Some of it is earlier, some of it is later, and then the secondary bullets is just what you would see in an assessment that would be done by a speech pathologist. So you'll see patients with lip weakness having spillage out of their mouth, or difficulty manipulating food, whether it's because their tongue is feeling heavy or weak, or because their tongue range of motion, just like arm range of motion, is affected. So they'll have food pocketing between, let's say, their teeth and their cheek. They sometimes talk about scooping it out because they can't reach up there to get food out, or stuck in the roof of their mouth. The delayed initiation of a swallow. So a lot of us can hold liquid in our mouth and then when we're ready, swallow it, but sometimes there's a delay with the rest of the mechanism. So the liquid can move back before they're ready to close off their airway, and then that can result in airway penetration. Or if their cough is weak, their airway is not as protected, they're at a higher risk for choking on food. And they'll talk about residue, so sticking sensations, and they'll often point here when they're talking about sticking, and that means that most often it's with solids that the food has not been fully cleared from their pharynx, and it's sitting in a very precarious position above their airway. So here you'll see what is called a video fluoroscopic swallow study. It's basically a video x-ray. It's not too clear here, but what you can see is in the front, you'll see the black in a trace amount dripping into that tube. That tube is their airway. So we don't want this to happen. Like I said, it's not very clear. I don't often suggest this video x-ray for this patient population because I feel that their swallowing can be managed with a thorough bedside assessment. In addition to that, it's very hard to get this kind of assessment for our patients as outpatients. Those of you who serve in the GTA may be familiar with the fact that the wait list can be 3, 6, 9, 12 months long. So it's better to send a patient to a speech pathologist who feels comfortable managing their swallowing without needing this x-ray, just based on symptoms and an oral mechanism exam and a clinical swallow examination. So what do we do then? We talk about modification of liquids. So we talk about thickening the liquid to slow the movement to keep up with the slowing muscles. This isn't a clear black and white because we are really concerned about hydration, and patients can be dehydrated because they're scared of choking. They've had experiences coughing on liquids and being breathless, but then they also don't really like the artificial thickeners. And so although there are a lot of products out there that can artificially thicken, Nicole and I really talk about naturally thick liquids. So boosting calories with the supplements and blending in fruits and having a naturally slightly thicker liquid, but we also don't want it to be so thick that they can't swallow either. So there's a fine balance, and this is where having an open discussion with the patient is important. We talk about single sips at a time and keeping the head down. So a chin tuck is basically bring your chin to your chest to better protect the airway. It, again, doesn't always work for patients because they can get to a stage where that impedes their swallowing rather than helps. And Karen talked about the nosy cups. You've got some pictures there that, again, encourage patients to keep their head in a neutral or down position to better protect their airway when they're swallowing. Straws are a big concern. So I'm sure a lot of you come across this when patients are drinking with straws, or they ask, is it safe? Or you're wondering. It's, again, not black and white because respiratory status is something we're very concerned about. So when using a straw, if you know that they're on BiPAP, or if you know that they are using a cough assist machine, you have to be much more cautious in recommending to them that they monitor their respiratory status when using a straw. So if they're coughing, clearing their throat, if they're short of breath after using a straw, those are signs that liquid could be moving too fast into their pharynx and then falling also into their airway. The one-way straws basically allow the liquid to stay in suspension, so it reduces the amount of sucking they have to do to pull the liquid up a straw. Those can be purchased online. It really maximizes independence for especially those patients who have limb onset where they can't feed themselves anymore, and they're more likely to stay hydrated if they can feed themselves. So again, it's discussing the risk, accepting possible risks of drinking liquids through a straw, and balancing quality of life and maintaining hydration. Solid food, we talk about it being easily chewed, it being moist so it moves back easily, but also some of these other little tips. So talking about avoiding consistencies where there's a liquid and a solid together, like chicken noodle soup, something as simple as that, or Cheerios with milk. In the same way, taking medication with a food carrier rather than liquid. Patients will talk about, oh, I have to drink so much water to get that pill down, or I can feel it sitting here. We don't want it sitting there. So yogurt, applesauce, a mashed up banana, those are ways to take medication safely. And of course, we also talk about, like Nicole said, smaller meals, smaller mouthfuls, chewing well, and if they're safe with liquids, just follow the food with a sip of liquid to kind of clear that residue that they sense. Coughing versus choking. So I know Dr. Tannen also talks about this, and Paula with our patients, if you're coughing, if a patient's coughing, they're coughing. That's a good thing. That means that their vocal cords are coming together. They're able to get air in and out. It is very distressing. I mean, those of you who've experienced it, those random occasions that have happened, but we don't want patients and their family members especially to panic. We want everyone to stay calm as the patient then coughs out as much as they can and resumes eating once they feel comfortable. Choking, on the other hand, is what we really, really want to avoid. And that's where the airway is completely obstructed. And often the patients need something like an abdominal thrust to clear their airway. So then we talk about educating family and caregivers, PSWs, friends, in knowing what to do in that situation and looking for the dangerous signs. So for dysphagia, some of the big take-homes I want you guys to think about is the fact that breathing, like we've talked about already, can have a large impact on the risk of choking, the risk of aspiration. If their cough is weak, these are some of the things you may want to ask when you're screening, when you're doing an intake is, oh, if you have these issues and the speech pathologist hasn't seen them, especially those who live far away, can't always come into the clinic, or it's been a while since they've come to the clinic, they may need a referral to us or to a CCAC speech pathologist to assess their swallowing. Even though they report that they're completely fine, those breathing changes are really concerning. BiPAP and cough cyst being flags that you could use. And we talk about accepted risk for quality of life. We want them to eat safely. We want them to follow what is the most efficient, safe way of eating, but it's their life. So as clinicians, yes, we convey what is the safest way for them to eat. We talk about the risks of them choking on certain food or liquid, and then tell them in the end it's their choice, and we support whatever their decision is because they fear being reprimanded, and then they eat less. So we just want them to eat at a certain point, especially if they decide not to go the feeding tube route. It becomes even more crucial to talk about accepted risk and document. Oral hygiene, very important. I'm not going to labor it. We basically want to make sure we're looking in these patients' mouths and encouraging regular hygiene, especially for those who can't do it for themselves, but even those who can. Regular cleaning of their mouth, their tongue especially, and paying attention to their tongue. So sometimes a speech pathologist or a nurse is the only person who looks into the patient's mouth. If they're not taking any food by mouth, they can still get aspiration pneumonia because there's thrush building on their tongue. And patients don't know to look out for that, so we need to be better at identifying that, mentioning it to them, and have them discuss it with their care provider, a physician who's caring for them, who can prescribe something to clean their tongue. Excess saliva, so some patients have too much. We take for granted how often we swallow our saliva and how much we produce. And what happens with these patients is that automatic reflex is no longer as automatic. What do? If it becomes bothersome to them, if it's interfering with their speech, or if they're choking on their saliva or clearing their throat often, our physicians can prescribe atropine, which is a droplet, or Elavil, which is a medication, to try and resolve that. In some cases, if neither of those and none of those medications are working, they may be referred for Botox injections to the salivary glands, or in some cases, radiation. Patients also have thick secretions, which we talked about, clearing those with the cough assist machine. Sometimes medications like SSKIs are prescribed to try and break up the secretions. If it's secretions in the mouth, in the oral cavity, and they're safe when it comes to their swallowing, some of these juices, these natural solutions, might help break up the mucus in their mouth. So some of the questions that patients ask, I already talked about video and about straws, and Nicole touched on Can patients eat with a feeding tube? So yes, they can. If they're safe to swallow, it's an easy yes. If they're having challenges, then again, it's that discussion about accepted risk for quality of life. As long as they understand, then we support them fully. Speech changes. So dysarthria involves changes to your articulation, your voice. Really what I focus on is education and compensatory strategies, early education, and then my colleagues will talk more about alternative communication. Here again, you'll see some of in the primary bullets, some of the symptoms they report. So feeling heavy tongue, that their speech is slurring initially intermittently and then more consistently throughout the day, that their voice feels weak, sometimes like they're being strangled, depending on the upper or lower motor neuron involvement, and hypernasality, which I feel like a lot of people feel is a trademark with ALS, but is something that not all of our patients have, and breath support being an issue where they're trailing off at the end of sentences, where they're taking short breaths or words are getting cut out. So these are some of the characteristics. This is my big point for a lot of us is, again, like Karen talked about physical exercise and the research. When it comes to speech, the current research, you can see some of these articles published as recently as 2016, still say that speech exercises, voice drills are not indicated for this population. So it's a little bit more black and white than even the physical exercise. Part of it is because unlike other body muscles, we use our speech muscles naturally. We exercise them by talking. So unless somebody is going to be recluse and not having any conversations, they're naturally exercising these muscles in the best way possible. And we don't want to fatigue muscles that are already weak. And it's difficult to exercise just your respiratory muscles or just your phonatory or just your articulatory, so your lips and your tongue, without involving the other muscles that may be compromised. So instead, what we focus on is behavioral interventions. So compensatory strategies such as phrasing, not sounding robotic, but I use the example of people talking like a presenter. Now, I'm not pausing that much, but let's think about a politician who uses lots of natural pauses. It allows them to take breaths at the right time. Exaggerating their sounds. Again, they may think they sound unnatural, but it comes across much clearer because they're able to get their consonants out. Being face-to-face. So instead of a phone call, nowadays we have WhatsApp video, Skype, FaceTime. It allows a person to have the voice interaction, but also the face-to-face where their communication partners can read their lips. We want to make sure we optimize the hearing of those around them, because that is on occasion an issue. So making sure that we have everyone in the family confirmed to have normal hearing, because we don't want both people working extra hard. Reducing background noise, and then education for communication partners. So there is a clinic in Boston that it's the Boston Children's Hospital, but they have an ALS augmentative clinic, and they have this checklist. You can look that up. It's really great for tips for family members. So if you're talking to family members about things that other ALS patients have said, please don't do this, please do this, it's a good tip sheet. And the AAC, which will be talked about by my colleagues. Voice and message banking also will be talked in a little bit more detail by my colleagues who are presenting next. But as the speech pathologist, or as people in the community who encounter patients who are early on in their disease progression, voice banking is something that should be screened by a clinician for, because really what they need is near normal speech and voice. It is very labor intensive. It requires hours and hours of recording with equipment and with model talker, which Cecilia, my colleague, will talk about. We don't want them embarking on this journey, coming out, not realizing that it's still going to be a somewhat synthesized voice, and also that it doesn't sound great because their speech has already changed a little, and they only realize it when they get this voice at the end. Message banking is much more forgiving, also easy for a lot of languages. So voice banking is a bit of a challenge, it's more for English. But with message banking, it's much easier and more natural. And again, Cecilia will describe what that exactly is in a bit more detail. But it can be very powerful for our patients. It's remarkable. Calling a dog because there's a recorded message of a woman saying, come here to their dog, and the dog recognizes it because it was recorded when their speech was normal. Some frequently asked questions. I already talked about my stance, but a lot of specialist stance on speech exercises at this point in the research, which was be a blanket no. Should I talk less? No. We want people to conserve their energy, which is important, but we really want them to use their speech as much as they can while they have it. Communication is so powerful, and in the same way, we want them to use it. It's not an, if I don't use it, will I lose it kind of stance. It's more just use your speech as much as you can. Use your voice. Just don't strain yourself. Don't fatigue yourself. Don't frustrate yourself. That's when a lot of these augmentative options come into play. The tough question at the end, how long will it take before I can't talk? We hear this a lot. We hear it from different disciplines. How long will it take before I can't eat, can't walk, can't breathe? So what I say to patients is, I'm sorry, I can't give you that clear timeline, but what I can say is that we are here for you as a team, and we'll work with you every step of the way so you don't fall through the cracks, so that you are still able to communicate near the end of your life, and so that you're still getting nutrition, if that is your wish, by whichever means, as long as we're involved in your care. Thank you. Please approach me after with any questions.